Great. Welcome everyone to the House Healthcare Committee. It is Tuesday, March 21st, the second day of spring. And today we are doing an overview of pharmacy benefit management. I'm going to say, at least for me, this has always been extremely confusing. So we'll take it as slow as we need to. This is all we have on the agenda for the afternoon, but we will finish by 3:45. Just again, because I have a feeling there's going to be a lot of questions, just raise your hands so we're not talking over each other, and I'll make sure that we move the conversation along. So I'm going to turn it over to Sebastian.
Great. Good afternoon, everyone. I am Sebastian Arduengo, and I am testifying for the Vermont Department of Financial Regulation. So by way of background, last year in Act 131, the committee asked us to draft a report looking at a bunch of different aspects of the pharmacy benefit management industry. And we spent most of the summer and a good chunk of the fall working on it. And the total report, printed out here, comes up to about 65 pages. Which is by far the longest report that I've worked on since I've been at the department, and will give all of you an idea of how complex and involved this topic is. So that being said, it is a big chunk of our healthcare industry. According to an estimate that was published by the Green Mountain Care Board, I think in 2021, something like 11.2% of all premium collected goes towards pharmacy and prescription drugs. And pharmacy benefit managers are a big part of that industry. But I think to get a real idea of where pharmacy benefit managers sit in the prescription drug value chain, it helps to understand who all of the different players are in the value chain and what they do. So that is why I brought this whiteboard here, because oftentimes this is represented as this big spaghetti chart with lines going every which way to different parties representing different things. So I wanted to try using this decidedly low-tech whiteboard to just try and illustrate everything one step at a time. That way we can talk about each party on their own without getting too deep into the weeds of how they interrelate with everyone else and just get confused. So I think the good place to start when we're talking about prescription drugs are what is a prescription drug. So very, very broadly speaking, there are two big kinds of drugs. There are over-the-counter drugs, which you can go and you don't need a prescription. You can just get them from the pharmacy. This is your Tylenol and Advil. And then there are prescription drugs that you need a prescription for. And what makes prescription drugs largely different from over-the-counter drugs is that prescription drugs are covered by third-party payers like Medicaid, like commercial health insurance. And the way that those payers pay for prescription drugs is completely different than the way that those payers pay for other medical services. But to get an idea of how the value chain works, I want to step away from those payers right now and focus on how a self-pay patient would pay for prescription drugs and how a pharmacy makes money off of that. So the first entity that we need to understand in the supply chain, and for those of you who have the report, we're starting, this is an excerpt from pages 2 to 5. And the report is on the legislature's website.
So if we, let's just take a second here. So if we go to the fine legislative reports, actually, Claire, can you post it?
I will post it.
We'll just have.
Yeah, please do.
If you go to our reports and resources tab, it's posted there
Okay,
under Department of Financial Regulation.
so under
Oh.
healthcare.
Yeah.
And if you don't want to go there, that's fine, but I know some people follow along. So, all right, well, everyone's looking for it. When's
Okay.
it going?
So the first entity that I want to introduce are the drug manufacturers, also lovingly referred to as Big Pharma.
Or not so lovingly.
Funny.
So these are entities like Pfizer, like Merck, like Eli Lilly. You've probably heard of them. And in this context, when we are talking about drug manufacturers, what we mean is the entity with the FDA license to sell a prescription drug. This is, of course, a bit of a simplification because of business being what it is. Things can be outsourced and contracted for. So you can sometimes have situations where a drug is, for instance, being manufactured by a subcontractor in a place like India, then being sold in the US under a licensed manufacturer's license. But for our purposes, the manufacturer is the entity with the FDA approval to sell a prescription drug. So they sell directly to wholesalers. So Representative Black can see that's where we are now, of manufacturers selling drugs to wholesalers. And what the wholesalers do is a lot like what wholesalers in any other industry do. They are the ones who are basically taking the warehousing risk of keeping all of these different prescription drugs on order for whenever a client needs them. So there are a few big wholesalers, and for the bigger chain pharmacies, like your Walgreens and CVS's, they will contract directly with those wholesalers to buy prescription drugs. So that introduces us to the third spoke on this supply chain, which are the pharmacies. So, what about the smaller pharmacies? I mean, if a small community pharmacy in Vermont were to call one of these enormous wholesalers, they're probably not going to get past the receptionist. So there are entities called group purchasing organizations that buy from these wholesalers and sell to the independent pharmacies.
What's the general purchasing or G?
Group
Purchasing.
purchasing organizations, or GPOs. So this is, now we're going to get into the first part, or the first of many terms of art in the PBM discussion that's important. So the price at which wholesalers sell to pharmacies is the wholesale price.
This is where I get confused.
Here we go.
There we go, it's right, Art.
This is where I get off the train.
Here we go.
Okay. So wholesalers sell to pharmacies at wholesale price. So at this point, we are no different from the hardware store that's buying product from their wholesaler. They're able to buy a bunch of drills or chainsaws or hammers or what have you at the wholesale price, and then they will make money by charging a markup to the eventual consumer. In the pharmacy space, what happens is that there are entities that look at what pharmacists around the country are paying at wholesale, and that number is the average wholesale price, or AWP. So that's a term that will come up a lot in our discussion of PBMs. So I'll put that on the whiteboard. So the collective average price that's paid at wholesale for prescription drugs is the average wholesale price. Okay, everyone with me so far? Okay, so now we have the patient that goes to the pharmacy. So remember, the difference between a prescription drug and an over-the-counter drug is that you need a prescription to get a prescription drug. So we say the patient as the last person in this chain, but they can't buy these drugs without a prescription. So it's important to remember that there's the patient, but there's also the prescriber who gives them a script that lets them buy whatever prescription drug they need.
Can I go back one step and ask a question?
Yes.
The wholesale price to pharmacies, is that also the same price to the, well, not necessarily the same price, but is it the same terminology when a wholesaler sells to a group repurchasing organization?
Yes.
Okay, probably a different price.
It'll be a different price, but the same concept.
Same concept. Okay, thank you. Topper?
Where does the pharmacy benefit manager come in?
We're getting there. So right now we are talking about the value chain for someone who is a self-pay patient. Pharmacy benefit managers contract with third-party payers, and we're getting there. Okay, so what pharmacies do is they will, and again, this is for a self-pay patient, sell a drug to the patient at a list price that they arbitrarily set. And the difference between the list price and the wholesale price of a prescription drug is how a pharmacist makes money from a self-pay patient. So again, at this point, when we're talking about the pharmacy supply chain for a self-pay patient, we are basically no different from a hardware store. Where it becomes very different is that, well, most people are not self-pay when they go to a pharmacy. They're covered by commercial health insurance or Medicaid or Medicare Part D, and have someone else paying for their prescription drugs.
How do they set the list price for a self-paid patient?
The pharmacy can set it wherever they want. Basically, it's for this part of the equation, it is no different from whatever a retail markup might be for any other consumer good.
But that's the pharmacist's discretion.
Yes. So lots of patients have insurance of some kind. Medicare Part D, Medicaid, commercial. For our purposes, when we're talking about the value chain, we're going to refer to all of those entities collectively as payers. And the role that payers have in this system is typically to design the pharmacy benefit for their beneficiaries. So the payer is the one that says, here are the prescription drugs that we are going to cover. That is the primary role of the payer. Okay. So how do the payers do this? And this is where PBMs come in. So for a huge payer like Humana, they might be able to go to a manufacturer like Eli Lilly and say, we would like to buy your drugs at a discount. But they may not be able to do that to every manufacturer of every prescription drug. Similarly, when you get down into the size of health plans that we have here in Vermont, comparatively speaking, Blue Cross Blue Shield of Vermont and MVP are very small companies that would ordinarily stand no chance of negotiating anything like a volume discount for their members if they were to go directly to the manufacturers. So what the payers do is they contract with PBMs. Okay.
I'd like to ask one question.
Yeah.
How do the manufacturers, how are they I'm trying to figure out how they become payers. Are they part of that group of payers?
Do you mean like how the manufacturers get paid?
No, you label them all payers.
Oh, so the payers are all of the health insurers that we typically think of, Medicare Part D, Medicaid, commercial insurance. Yeah,
Go ahead.
Just so, PBMs, are they cutting out the whole wholesale thing? They're
no,
going directly to the manufacturer? Is that,
no. So I've tried to draw it like this for a reason. And what I was going, my big reveal, which I'll reveal now, is that
reveal, that's cool.
All right, y'all have a little too much fun talking about pharmacy benefit managers.
so on this side, we have supply. On the bottom, we have demand. And on this side, we have where the money flows.
Okay, it's just that you had just said that PBMs will just, because they can do it in bulk or large payers,
Yes,
then they can go directly to the manufacturer,
Yes,
which
and we're-
is that cutting out the
and
wholesalers.
we're going to get there.
Oh, okay, sorry.
So
Jump ahead.
the PBMs do not directly purchase drugs. I think that's important to note here. The PBMs do not directly purchase drugs. What they do is they go to the manufacturers and say, we have 40 million members in 13 states, and we would like a discount on the prescription drugs that we think our members will need. And these discounts are applied in the form of rebates that the manufacturers give to the PBMs. And then what the PBMs do is that they will develop, among other things, formularies. Okay. And what a formulary is basically a list of all of the prescription drugs that are covered under a particular pharmacy benefit design. So the way it will usually work is that, for the sake of simplicity, we'll say that a formulary might have 3 tiers, and each tier has a different level of patient cost sharing associated with it. So for your tier 3 drugs, you might have $100 of cost sharing per script. And then for tier 2, it might be 50 per script. And then for tier 1, it might be 25. That's what the PBM does, is that they will help their clients, which are the payers, develop these formularies based on the rebates that the PBM has negotiated with the manufacturer. Is everyone with me so far?
Is everyone good?
I'm good. I just want to get, if you could put that chart up again.
Yep.
Please. The payers. Who is the patient and the prescriber? Who are the payers?
So the payers are the health insurance plans. So for instance, for a patient with Vermont Medicaid, the payer would be Medicaid. Does that make
It's
sense?
across Blue Shield, it could be MVP,
Okay.
it could be Cigna, it could be any.
It could be Part D, yes.
Okay.
But it's not the individual one.
But it's not the individual, and that is a key point. When we're talking about folks with insurance of any kind, they are not the ones who are paying for the prescription drugs anymore. So now we're totally like outside of the realm of like how this might work at a hardware store or grocery store because of third-party payers.
So I have a question about that. So, but the patient still has a deductible.
Yes,
So, but that doesn't really play in, all this other stuff happens and then the patient's just told, this is what you owe for the deductible.
yes. So going back to the formularies, this sets what the patient's out-of-pocket is, not how much that drug actually costs.
Okay. Mari has a question. Mari?
Yeah, more of a comment, and I think as we become to understand how PBMs work currently, this I think will make more sense. But it may help to know that PBMs were originally designed decades ago, and the intent was to help health insurance companies when health insurance companies started to offer pharmaceutical benefits. Pharmacy benefit managers were designed and intended to help with the administration of drug benefits in health insurance plans. And then just another point to note, they've since grown, pharmacy benefit managers have since grown to the point where it's either 97 or 99% of the market share in the United States of PBMs is held by 3 companies that are both horizontally and vertically integrated, which has caught the attention of the FTC, Federal Trade Commission, and is one of the main reasons that we as a state developed the bill act that became Act 131. And there are a lot of problems associated with that, including losing many independent pharmacies across the country. It's not just our state, but it's really, we've lost quite a few independent pharmacies because of this. So sorry, I just thought that might be helpful.
Yep, that's helpful, but I do want to still just focus on the education piece here before we branch into what we did in 131 and problems we have. Leslie?
I'm just wondering if there's anywhere in your research, is there any other industry that operates in this kind of way? I mean, away from the hardware store into this kind of very complex third multiple levels?
Yes. So this is kind of the way that healthcare writ large works, in that you have services being paid for by third parties. And yeah.
No, keep going.
Go ahead.
Keep going. He's just letting me know he has a question.
Oh, okay. So if like trying to think about other industries that work this way, like certain aspects of the legal industry might work this way. For instance, if you are litigating a case and your lawyer is being paid by a third party, which is not uncommon, that could happen. But this structure of having third parties pay for services is really pervasive in the healthcare industry.
Art?
Yes, could you explain the rebates piece again? I got lost when you went from formulary to rebates.
Yes. Okay. So do you know when you purchase something and there's a rebate on it, you will like send in a coupon.
Sure.
And the manufacturer will send you money. It's the same kind of thing with the PBM. So the PBM will say, like, we're going to purchase millions of doses of, or our members are going to purchase millions of doses of X drug. What can you do for us?
Oh.
And in order to incentivize the PBM to put X on their formulary, they will kick the PBM some cash or some other benefit to make that happen.
Does the PBM have to apply for it like I would with a coupon or no? I know they wouldn't have a coupon. but
Yeah,
is it-
so the answer is yes, these rebates are like big business
Sure.
negotiation, big contract, that kind of thing.
So the money does change hands from the PBM to the wholesaler, but then the wholesaler gives some of it back
Patient.
to the
Yeah.
PBM.
Yeah, so manufacturers will give the PBM rebates, think
Okay.
about it as a monetary benefit.
Okay.
The PBM puts that drug on their formulary, and then that helps the manufacturer because then more pharmacies purchase that drug, and the manufacturer makes money when that drug is purchased.
Melanie?
Does the rebate ever make it to the patient, or how is it, does it stop at the PBM? Does it trickle down?
For the purposes of simplicity, we're going to stop it at the PBM for this 101.
Okay.
But just foreshadowing, there are some states that require full pass-through of rebates to the patient. Okay, so where we are is that PBMs are setting the formulary. The formulary says how much a patient has to pay out of pocket. But then you might ask, well, then in this scenario, how does the pharmacy get paid? So the pharmacy gets paid by the PBM. Does that make sense to everyone? And what the PBM says is that we will pay a set price for a given prescription drug. This is referred to as the MAC price, or maximum allowable cost. So when we're talking about this on Thursday, when we are talking about the MAC price, this is the price that the PBM is reimbursing the pharmacy. And what's important to note here is that the MAC price does not have any correlation to the wholesale price. So the pharmacist could make money on the difference between the wholesale price and the MAC price, or they could lose money on that difference. So then,
Wait, can we stop there for a second?
yes,
I'm looking at my notes. So the wholesaler determines, they sell to the pharmacies and they set the wholesale price.
yep,
So the pharmacy in that, on this side of it, but that's only self-pay.
yes,
So on the PBM side, the wholesaler isn't involved at all.
yeah. So the wholesaler is still involved on the patient with insurance side.
Okay.
So the pharmacy has to pay that price to get their product, no matter who the third party payer is.
Gotcha.
It's just that with their self-pay patient, they get to set the list price, and they'll make a nice retail markup. But for the third party payer, they have to accept the maximum allowable cost.
Makes sense. Thank you.
So the list price can include like overhead and all of that, but the MAC price, not necessarily.
Not necessarily. And I think that will go a long way towards providing some background to some of the other topics we'll talk about on Thursday. So the PBM is reimbursing the pharmacy. So that brings us to the second big service that PBMs provide, which is claims processing. So for your typical health insurance claim, for instance, if there was a patient who was insured with Blue Cross Blue Shield of Vermont, they had a medical claim, Blue Cross will process that claim itself and receive all the clinical information about the claim and reimburse the provider. Blue Cross will do that. For a prescription drug claim, the PBM will process that claim and then get reimbursed by the payer. And then the payer will collect money to pay those claims out of premium. But the thing that I just want to point out to all of you is that in this third-party payer money chain, we have the money going from the patient and their premiums to the payer, who then pays the PBM, who pays the pharmacy. That is the very rough chain of money in this value chain.
Could you put arrows there for a minute? You said PBM pays payers, and then payers, were there arrows,
Yes.
the reimbursement, like I got confused with the arrow, the direction.
Oh, I'm sorry. So,
No, I mean,
so if we imagine money flowing this way,
yeah,
so patient's premiums go to the payer. And obviously when we're talking about premium, we're talking about commercial insurance because Medicaid beneficiaries don't have a monthly premium. Then the payers reimburse the PBM for pharmacy claims.
Mm-hmm.
Then the PBM reimburses the pharmacy at the MAC price.
Mm-hmm.
And I think one more thing that I want to note here is that this amount also has nothing to do with this amount. So the amount that the payer reimburses the PBM may or may not be related to the amount that the PBM reimburses the pharmacy.
Go ahead, Jason.
Is that regulated at all?
We will get there on Thursday.
That's where we're going.
That is where we are going.
That's the spread pricing.
Yes.
And so I have a question. Remind me again, the PBM sets both the amount that the payer pays the PBM and the MAC price.
Yes.
The PBM is basically controlling that whole circle right there.
Yes. So where the PBM sits in this value chain, they are the only parties that are contracting with payers, pharmacies, manufacturers. So they are usually the only party in this value chain that has a really good idea of what the prices are at all levels. And not to get too far ahead of myself, that it is conferred a substantial competitive advantage to them.
Alyssa and then Leslie.
I'm thinking about what happens when the PBM becomes pharmacy, or the payer becomes the PBM.
Yes.
Becomes the pharmacy. Does all of these still happen, or we're getting
Yes.
another acronym price?
So this still happens to an extent. So for example, CVS Caremark is both a PBM and a pharmacy, but under the terms that the Department of Justice imposed when CVS and Caremark merged, the pharmacy side of the business is firewalled from the PBM side of the business. That being said, if you are an independent pharmacist, you might still feel like you're in the position of relying on a competitor effectively for reimbursement, which is not comfortable.
Right. Leslie and then Alan?
And I think the thing that we learned that's important is that PBMs are for-profit corporations that have shareholders. So their whole motivation is very different than, let's say, Blue Cross Blue Shield, who's a nonprofit.
Okay, so who are they held accountable to?
They're held accountable to shareholders.
The shareholders, okay, it's a corporation.
So on Thursday, we'll talk more about how Vermont regulates these PBMs and how other states regulate these PBMs. So that is an introduction of setting the stage to the prescription drug value chain and who all of the players are.
So can we leave that here for
Yes.
Thursday or bring it back?
Yes, I will leave it right here.
Yeah, I think that will be helpful because we'll.
Take a picture right in on our-
Well, we have some.
Oh, true.
I will leave it right there and pick it back up on Thursday.
Great, thank you. Well, before you get up, any last questions for?
Well done.
Yeah, that was very,
Is that a new
Thank you.
dry erase board?
Yes.
Very well done.
There'll be a test afterwards.
You're willing to leave it with us.
Quiz.
all right, Jen.
Yes, let me join this Zoom.
You know, why don't we, let's take a no more than 10-minute break. So be back at